Hey Vault Squad, welcome back to the Pharmacology Vault, where we decode pharmacology, one drug class at a time. Today's topic is the antagonist of our last episode. That's right, we're covering anticholinergic drugs, also known as muscarinic blockers, atropinic agents, or parasympatholytics. These drugs are essential in emergency medicine, anesthesia, respiratory care, and more. So if you're a med student, a pharmacist, or just curious, stick around. This one's loaded with high-yield content. Anticholinergic drugs block the effects of acetylcholine, but not everywhere. Specifically, they block muscarinic receptors found in organs like the heart, lungs, eyes, gut, and bladder. By doing so, they inhibit parasympathetic activity, leading to effects like reduced secretions, relaxed smooth muscles, increased heart rate, pupil dilation. In the CNS, they can affect cognition, motion sickness, and motor control. In the PNS, they influence smooth muscles, glands, and cardiac function. In the central nervous system, anticholinergic drugs can influence cognitive functions, memory, mood, and movement coordination. For example, trihexyphenidyl and bupiridine are used to treat Parkinson's disease and drug-induced extrapyramidal symptoms by restoring the balance between dopamine and acetylcholine in the brain. But, in higher doses or in elderly patients, anticholinergics can cause confusion, delirium, and even hallucinations. That's why they're considered risky in conditions like dementia. So in the brain, these drugs can be both therapeutic and toxic, depending on how, where, and how much they're used. Now let's move to the peripheral nervous system, where the effects are much easier to observe and remember. Here, anticholinergic drugs affect organs that are normally regulated by the parasympathetic nervous system, the rest and digest system. In the heart, they can increase heart rate by blocking vagal tone, which is useful in bradycardia. In the lungs, they relax bronchial muscles. That's why drugs like Ipratropium and tiotropium are used for asthma and COPD. In the GI tract, they reduce motility and secretions, helping treat IBS, GI spasms, or nausea. And in the bladder, they reduce detrusor muscle contraction, helping with urge incontinence and overactive bladder. In short, anticholinergics in the periphery are like hitting the pause button on parasympathetic functions. Less saliva, slower digestion, fewer secretions, and relaxed smooth muscles. Let's categorize them. Anticholinergics are divided by site of action and chemical type. Here's a simplified breakdown. Muscarinic antagonists. These block acetylcholine at muscarinic receptors and are the most widely used group. Ganglionic blockers. These inhibit ACH transmission at autonomic ganglia, rarely used now due to broad, unpredictable effects. Neuromuscular blockers. These target nicotinic receptors at skeletal neuromuscular junctions, used in anesthesia. Let's dive into the classification of anticholinergic drugs, also known as muscarinic antagonists. Atropinic drugs, or parasympatholytics. All of these names refer to the same thing. Drugs that block acetylcholine at muscarinic receptors, and they're classified based on their source, structure, and clinical use. Natural alkaloids. These are the original anticholinergics, found naturally in plants like belladonna and henbane. They serve as the prototypes for all other muscarinic blockers. Examples include atropine, the gold standard in this class. Hyoscine, also known as scopolamine, especially effective for motion sickness. These alkaloids have both central and peripheral actions, and are foundational for understanding anticholinergic pharmacology. Semisynthetic derivatives. These drugs are chemically modified versions of natural alkaloids, designed for better selectivity, absorption, or fewer side effects. Examples include atropine methonitrate, a more stable form of atropine. Homatropine, used in ophthalmology for eye dilation. Hyoscine butyl bromide, commonly used for GI cramps and spasms. Ipratropium and tiotropium bromide, inhaled agents used in asthma and COPD. These are more targeted in their action, with some optimized for local delivery like inhalation or topical use. Synthetic compounds. This is the largest and most diverse group, further divided based on their clinical use. Let's walk through the key subcategories. Mydriatics, used for eye dilation. These are short-acting anticholinergics used by ophthalmologists to dilate pupils and relax accommodation during eye exams. Cyclopentolate, tropicamide, faster onset and shorter duration than atropine. Vesico-selective agents, for urinary disorders. These drugs are bladder-specific, used to treat overactive bladder and urge incontinence by relaxing detrusor muscle. Key drugs include oxybutynin, flavoxate, tolterodine, darafenacin, solifenacin. These are especially useful in elderly patients with urinary urgency or frequency. Antiparkinsonian agents. These drugs act centrally, helping correct the dopamine-acetylcholine imbalance in Parkinson's disease or drug-induced extrapyramidal symptoms, EPS. Examples: trihexyphenidyl, benzhexol, procyclidine, bipyridine. They reduce tremors, rigidity, and stiffness in movement disorders. Antisecretory and antispasmodic agents. These are used to suppress GI secretions, smooth muscle spasms, or manage abdominal pain. This group is divided by CNS penetration ability. Quaternary compounds, low CNS penetration. These are charged molecules that don't cross the blood-brain barrier, making them ideal for peripheral actions like reducing secretions or controlling gut spasms. Propanthyline, oxyphenonium, clodinium, Homatropium bromide, isopropamide, glycopyrrolate. You'll often see these in pre-op settings to reduce saliva and respiratory secretions. Tertiary amines, better CNS penetration. These are uncharged, so they do enter the brain, giving them both central and peripheral effects. Key examples: dicyclamine, for IBS and abdominal cramping. Valethimate, used for uterine spasm relief in labor. Pirenzepine, once used for peptic ulcer disease due to selective M1 receptor blockade. They offer more versatility but can also cause more CNS-related side effects like confusion or dizziness in older adults. So that's your complete map of anticholinergic drugs, from natural plant alkaloids to precision-designed bladder relaxants. Understanding this classification not only helps in memorization, but also guides how and why each drug is used in clinical practice. Let's explore where these drugs are used, and why they matter in daily medical practice. Let's start with one of the most common uses, pre-anesthetic medication. Before surgery, patients are often given atropine or glycopyrrolate to reduce salivary and respiratory secretions and prevent bradycardia caused by vagal stimulation. These drugs keep the airway clear and the heart rate stable during anesthesia. Next, motion sickness or nausea caused by travel or vertigo. Here, the go-to drug is Hyoscine, also known as scopolamine. It blocks muscarinic receptors in the vestibular system and vomiting center of the brain, making it great for seasickness, car rides, or post-op recovery. In chronic obstructive pulmonary disease or asthma, we need to relax the airways. Ipratropium and tiotropium bromide are inhaled anticholinergics that reduce bronchoconstriction and mucus secretion. They're essential components of long-term respiratory therapy, especially in COPD. During an eye exam, we often need to dilate the pupil and paralyze accommodation. This is where atropine, homatropine, cyclopentolate, and tropicamide come in. These drugs temporarily block the eye's sphincter muscles, allowing clear visualization of the retina and lens. Before PPIs and H2 blockers changed the game, anticholinergics were used to reduce gastric acid secretion. Pirenzepine, propanthyline, and glycopyrrolate were commonly used for this purpose. Although now mostly obsolete, they're still worth knowing for pharmacology exams. When patients suffer from involuntary bladder contractions or urgency, oxybutynin, tolterodine, solifenacin, and darafenacin come to the rescue. These are vesico-selective antimuscarinics that relax the detrusor muscle, helping reduce urinary frequency and incontinence. In Parkinson's disease, and in extrapyramidal symptoms caused by antipsychotic drugs, there's often an imbalance between dopamine and acetylcholine in the brain. Trihexyphenidyl, bipyridine, and procyclidine help restore this balance by reducing cholinergic activity. They're especially useful in controlling tremors and rigidity, abdominal cramping, spasms, or irritable bowel syndrome. Dicyclamine, hyoscine butyl bromide, clodinium, and valethimate are effective antispasmodic agents that relax GI smooth muscle and reduce pain. During surgery, especially when a patient is intubated or under general anesthesia, secretions can interfere with airway management. Glycopyrrolate and propanthyline are used to reduce salivation and respiratory mucus production, making the procedure safer and smoother. Lastly, in labor and delivery settings, valethimate bromide may be used to relieve uterine spasms and aid in cervical dilation. Although not a first-line choice everywhere, it's still in use in some obstetric protocols. And that wraps up the clinical uses of anticholinergic drugs. From pre-op prep to Parkinson's, from airways to bladder, these medications play a vital role across specialties. If you found this helpful, don't forget to like, share, and subscribe to the Pharmacology Vault for more clean, clinical breakdowns of essential drug classes. Until next time, stay curious, stay caffeinated, and keep unlocking pharmacology.